Thank you for everybody who still stick around the last day. So my topic today is design needs for cardiovascular device occluders. I'm giving this talk on behalf of Dr. Ruiz. I also, since the last two speakers spoke a lot about left-right appendage occluders, I'm going to steer away from that and so also give you some insight about that. So I don't have any disclosures. Dr. Ruiz's disclosures are listed. So there are many limitations to the currently available cardiac devices. If you look at them, they're mostly off-label. Very few are on-label here. And in this particular case, which is a very large aortic PBL, AVP2 devices are used. And as they took care of the problem, they created a new problem here, which was LVOT obstruction. So those were retrieved and sort of more of a ADO devices were used. So it's very difficult to predict which one is going to be useful and what kind of devices are most beneficial to which kind of defects you're going to cause. So most of the cons with this device is one, as I mentioned, it's mostly off-label. And they're very abrasive. They're made of nitinol woven structures. They can be cause injury to adjacent structures, perforations, you're talking about corrosion in the long term, and also they can cause hemolysis as well. And any foreign body in the is increased risk of infection, and these devices are no exception here. And also they're prone to dislodge. And depending on how you size them, how the tissue characteristics are, or even in the future, if there is an infection which could increase the device tissue characteristics, and devices can dislodge. And they don't conform. It's almost like putting, as I say, a square peg in a round hole. Where do we use these devices? There are numerous applications. You're looking at vascular applications, cardiac applications. Briefly, we'll go through some of them. Vascular, you're looking at various shunts, aneurysmal cavities, which our neurosurgical colleagues, most of them close in the cerebral, for cerebral aneurysms. There's also a lot of bleeders, even a retroperitoneal bleed that can be closed with some of these vascular plugs. When you come to the cardiac, the use is even more broad. You're looking at shunts, more ASDs, VSDs, PFOs, and also you're looking at paravalvular leaks, both aortic and mitral. Aneurysmal cavities, this includes left ventricular, atrial, or even aortic aneurysmal cavities. Left radial appendage occlusions, as we talked about this today, and also perforations, which can be acute, including post-MI perforations. So in the vascular world, including shunts, there is arterial, arteriovenous, as well as veno-venous shunts that can be closed. We talked about cerebral aneurysms. I just put in a couple of examples here, which are a lot more complex in the sense. On the top picture, you see a major aortopulmonary capillary artery occlusion. Here, we're using coils and AVP2 devices to close a major shunt that's occurring due to a MAPCA. And in the below picture, you see a pulmonary AVM closure. So there's a huge aneurysmal pulmonary AVM, as you can see in the picture on the left, which is actually closed by, again, I think it was an AVP2 device as well. So when you come to cardiac, the users go further. So you're looking at shunts, which is the atrial or a ventricular shunts. On the top left of the figure, you see a VSD being closed with a ADO device. And again, it can be even more complex. On the right picture, you see a Restelli procedure, which is adult congenital heart procedure, wherein you have a conduit from the right to the PA. And there was a shunt crossing across from both from the atria that needed to be closed, which was causing a lot of shunts. So as you can see, two devices put in. Clearly, they don't conform to the anatomy of these structures there, but they work, and it is still not a complete closure. And on the bottom picture here, maybe I can play this again. Here you see a really complex PBL, which has a connection through a pseudoaneurysm into the LV. So here we used a septal and transapical rail, and then we used a large ASD device to close the LV aneurysm as well as the PBL through the aneurysm. So we're just being innovative, but clearly these devices are not designed for this kind of structural abnormalities. And of course, the left radial appendage is seen on the lower picture. So what are the types of device occluders that we have right now? So amplastic type of devices, which are vascular plugs. You see on the right corner, most of the in profile, right from AVP1 to AVP2, 3, 4, and you see a ductal occluder, ASD, VSD, as well as the new Occlutech device, which has been approved for PVL closures. But again, they're not, you're adapting these devices for something which is not meant to be. Apart from this, from the panels may use, this is Giantorco coils that people use for closure of aneurysmal cavities, especially neurosurgical colleagues. And there were some prior devices that we've been, I think they are extinct now. The first time I heard of a detachable balloon on a vascular structure, I was like, this is cool. I said, this has been done and tested. And you have Gore helix types of devices, and also there is something called a Sideri type of devices. You see in this particular here, it's actually a polyurethane patch which is placed on a double balloon and has a detachable sleeve, so you actually leave the balloon there for a closure of ASD or VSD, and the patch sort of takes or conforms to the device, and the balloon is retrieved later. So these devices, I think most of them are extinct, but you can see that none of them are designed for the structural abnormalities that we face every day. So what should a cardiac occluded device have? What should the characteristics be? First of all, it should provide a permanent hermetic seal to whichever closure you're trying to do. It should occupy minimal necessary space. This again, one, not to cause injury to the adjacent structures, and also you want to be minimalistic. It should be biocompatible and allow tissue integration, but not cause overgrowth. And again, overgrowth, as you can see, can cause more problems. And for deploying them, it should be visible on a fluoroscopy or even any other imaging diagnostics that you do. So it should be compatible with them and visible in them. And it should configure to the defect, and it's not the other way around. As you can see in the PVL world, at least, we were using ADO devices in the past, which are a lot more stronger, or let me put it that way. So once the AVP2 devices are less radial strength, so to speak. And they should have the ability to resist migration and embolization. There should probably even an anchoring system, I'm not sure, but some sort of mechanism which resists migration and embolization. They should be retrievable, adjustable, and repositionable. Again, there's a lot of ask, but I think these are the future we are looking at. And it should be easy and consistent. It should be easy to deploy, and it should be consistent every time you deploy them. And it should have accurate deliverability and compatibility as well. And at this structure, we're also talking about not only the device design, but also about the delivery systems itself, because delivery systems matter too in terms of delivering these devices. So I think they have to be torqueable, kink resistance, various other things that you're able to get with delivery systems. And it should be compatible with other structures and other implanted devices. We talked about this as well. An ability to resist corrosion. Most of the nitinol devices are corrosion resistant, but maybe in the future we don't even have to talk about nitinol devices. Maybe you're talking about even biocompatible devices. And ability to resist hemolysis and clot formation. This is more relevant in the PVL world. And ability to maintain structure and functional integrity for the expected lifetime passive device. So how does the future entail? I foresee this happening. 3D printing is right now a reality, and I think we're looking at a time where we are able to use imaging to sort of look at a defect and say, how do I tailor a device to this? And I think it's very close. And you can also do it virtual and imaging. Now we've got fantastic imaging, and you can actually place a virtual device. You can get the device STLs onto a device and then place them in 3D imaging structure and see if it fits. And that way you can actually tailor some of these devices. Thank you very much.